Welcome, everybody. We'll be starting our Advocacy Grand Rounds in just a minute. Vaccines under pressure, navigating science, misinformation, and political challenges. But before we get started, I wanted to take a quick minute to invite you to officially join Doctors for America and the DFA fight to improve healthcare for everybody. Becoming a DFA member is easy. Just go to the link in the chat, select your membership levels, and pay your annual membership dues to support all our work to improve healthcare with incredible programs like this Advocacy Grand Rounds series. I also wanted to note that tomorrow, April 24th at 8 p.m. Eastern Time, we will hold an all advocate town hall entitled Code Blue to inform and mobilize both current and prospective DFA members. There are urgent challenges facing our healthcare system right now, and we want to talk about what DFA is doing now and what we can do in the future to address them. Please see the link in the chat to register. We'd love to have you. Tonight, we'll be live streaming this presentation to Facebook Live as well as recording it. All materials will be available afterwards. A few quick ground rules for this educational session. We welcome your questions, and there is no such thing as a stupid question. Speaking of questions, please remember to use the Q&A feature on Zoom. We'll address your questions during the second half of the session. And also look out for comments in the chat. DFA staff will be sharing helpful links during the session. Now on to our speakers. We're thrilled to welcome Dr. Paul Offit and Dr. Judith O'Donnell. Paul Offit is the director of the Vaccine Education Center at the Children's Hospital of Pennsylvania, as well as the Maurice R. Hilleman Professor of Vaccinology and a professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. He is a recipient of many awards, including the J. Edmund Bradley Prize. This was for excellence in pediatrics from the University of Maryland Medical School, the Young Investigator Award in Vaccine Development from the Infectious Disease Society, and a Research Career Development Award from the National Institutes of Health. Dr. Offit has published more than 170 papers in medical and scientific journals in the area of rotavirus-specific immune responses and vaccine safety. He's also the co-inventor of the rotavirus vaccine, Rototec, recommended for universal use in infants by the CDC in 2006 and by the WHO in 2013. Dr. Offit was a member of the Advisory Committee on Immunization Practices to the CDC and is currently a member of the FDA Vaccine Advisory Committee. Most importantly, he's been a vocal advocate for vaccines, including authoring a book, Tell Me When It's Over, that addresses the public health response to COVID, and he writes a Substack, Beyond the Noise, that many of you might have seen. Dr. O'Donnell is a professor of clinical medicine in the Division of Infectious Diseases at the University of Pennsylvania's Perelman School of Medicine. She currently serves as the Chief Medical Officer at Penn Presbyterian Medical Center, where she is the Chief of Infectious Disease, a role that she has held since 2011. Since 2022, she's been the Associate Chief Medical Officer for Healthcare Epidemiology for the University of Pennsylvania Health System. She's a board-certified infectious disease specialist with more than 30 years of clinical experience in her specialty, and she maintains an active practice in ID, along with ongoing commitment to students and graduate education. Her specific areas of clinical expertise are many, but include respiratory virus infections, hospital-acquired infections, endocarditis, bone and joint infections, and sexually transmitted disease. I will now turn it over to Dr. Paul Offit to get us started.
Thank you. So you're trying to make Judy and I both sound Irish. It's actually opposite, but my daughter's married name is O'Connor, so there is an Irish strain to my family, but it's not me. In any case, thank you. I'm a child of the 1950s. Therefore, like all children, the early 1950s, I had measles. At the time, there were probably about 3 to 4 million cases of measles every year, roughly 48,000 hospitalizations and 500 deaths. When children were hospitalized or died, typically it was when they had measles pneumonia, which was actually fairly common. Even those who weren't hospitalized, there was a mild form of pneumonia often, or dehydration. Because measles was invariably also associated with diarrhea, which I think people may not have realized. So between the high fever, which was often true, often as high as 105 degrees Fahrenheit, and the diarrhea, that was a significant source of water loss, and also about 1,000 children every year would get encephalitis, about a quarter of whom would end up with permanent brain damage, either deafness or blindness. So this was not a childhood rite of passage. No parents back in the early 50s saw this as a benign disease. Measles made you sick. And I think when children come into our hospital, Children's Hospital Philadelphia, and have fever and a rash, and they're worried about measles, they'll often ask old people like me to come down there to take a look, because I can tell in 30 seconds whether it's measles. People are sick with measles. There's often photophobia. The lights are down. Children are miserable with measles. And so I think that was a feared and in many ways devastating disease. So by 1963, we had the first measles vaccines. They weren't great. The last best measles vaccine came in 1968. So we had a single dose measles vaccine in 1968, which dramatically reduced the incidence of this disease. Between 89 and 91, there were outbreaks that involved as many as 50,000 hospitalizations in this country, about 160 deaths. So in 89, we had a second dose recommendation. Although if you looked at the epidemiology of who was getting hospitalized and who was dying in the sort of late 80s, it was children who were never vaccinated. So it was really a second chance to get a first dose. That's why I always have trouble calling it a booster dose. It's really not a booster dose. It's sort of a second dose. And then what we did was, by the year 2000, between having a two-dose recommendation, having all 50 states with school mandates that were enforced, we eliminated the most contagious infectious disease of humans. I mean, this is there's something called the contagiousness index, meaning how many people will you infect during a typical day, assuming you have the infection, and assuming everyone you come in contact with is susceptible. For diseases like influenza or SARS-CoV-2 or RSV, respiratory syncytial virus, it's around 2 to 3, maybe 4. For measles, it's between 15 and 18. It's that contagious because it's not just a face-to-face transmission. It's an airspace disease. You just need to be within someone's airspace within 2 hours of them being there. When someone comes into our emergency department with measles and is taken back to a treatment room and has measles, you can't go into that room for another 2 hours until these little particles that hang in the air like a ghost settle. But we eliminated that disease by the year 2000. Remarkable, a remarkable achievement. What's happened, however, is it's come back. No, not more so than this year. We are in the midst of a raging measles epidemic. If you look at the CDC's website this morning, it will say that there are 800 confirmed cases, that it involves 25 states, that there are now 9 outbreak states. So outbreak means 3 or more cases in one state. And that is a vast underestimate of what's happening. If you talk to people on the ground in Texas, or you talk to public health officials, they will tell you it's at least 3,000 cases and could be as many as 5,000 cases. And that's deduced from the number of deaths. There have been 3 deaths. 2 of those deaths were in healthy little girls, one a 6-year-old girl, another 8-year-old girl, who they were well-nourished, healthy, and died of this disease. We've had 3 measles deaths this year. That equals the total number of measles deaths in this country over the last 25 years. And if you look at the doubling rate, and you see what's going on right now, and that in combination with the fact that CDC has limited resources, this outbreak is, we're not finished with this. We'll see how this plays out. I mean, I'm a veteran of the 1991 Philadelphia measles epidemic, when we had 1,400 cases and 9 deaths in our city. And as we were running around doing everything we could, we vaccinated down to 6 months of age. The Commonwealth gave millions of dollars to try and promote vaccination campaigns. And for all of our hard work trying to isolate and quarantine and vaccinate, I think what ended that epidemic was spring. I think by mid-May, it seemed to taper off. Hopefully that will be true now too. So why is this? Why is it that we're once again experiencing a disease that we eliminated from this country about 25 years ago? And I think there's 2 reasons for that. I think one is that not only have we largely eliminated measles, we've eliminated the memory of measles. It was surprising to me that when we admitted a child to our hospital at Children's Hospital Philadelphia with measles, most of the doctors had never seen a case, which is remarkable. So I think that's part of it. And the other part of it is a big part of it is just there's a flood of misinformation and disinformation about measles and about the measles vaccine. So I think this is what we're up against. We're up against, I think, disinformation. We're up against sort of this notion that this is no big deal. And I think our Secretary of Health and Human Services hasn't helped us here. He has misrepresented this vaccine on national television by saying things like the measles vaccine kills people every year, which is not true, that the measles vaccine causes blindness and deafness, which is not true, that the measles vaccine causes the same symptoms as measles, which is not true. And then more recently, this one actually upset me more than any of them, when he said that if you look at the WHO, World Health Organization, Eastern European region, that they've had 127,000 cases and 36 deaths. So we're doing better than that. But we are, and I quote, "We are the envy of the world." We're not the envy. We're not. First of all, if you're going to compare us to something, don't compare us to Romania and Kazakhstan. Compare us to Germany or France, where we're not doing better. And we eliminated this disease by the year 2000. Those two little girls who were healthy and died is an unconscionable moment in this country. And I think we're sort of just letting it slide like business as usual, and it's not business as usual. These are preventable illnesses, and I think medicine's hard enough. There's so much we don't know. There's so much we can't do. This we know, and any death is tragic. Any death in a child is tragic. But when it's preventable, it's even more tragic. So I think we need to really stand on our platform and loudly and clearly and unabashedly say, get vaccinated, because this is creeping up on us, and everybody's at risk. Everybody who is not vaccinated or hasn't been naturally infected is at risk. So I think that's what we need to really sound the alarm now, because this is a call to arms. Thank you.
Thank you very much. A lot of great information and very sobering too. And now, welcome to Dr. Judy O'Donnell.
Thanks, Lynn. I have a few slides that I'm going to share. Um, Thank you for sharing those. So I'm going to focus more on adults, since I'm an adult infectious disease physician. However, important to recognize that adults get benefits from the childhood vaccinations that we have done over these many years, all the time, and we don't necessarily always call that out, but um, keeping our children immune helps adults who have immunocompromise or who have other issues. And we've even seen that with the measles epidemic that Paul just referenced. So I'm going to talk about three things. I'm going to talk about flu vaccine. I'm going to touch on pneumococcal vaccine. And then I'll just end up with a couple of comments about how the measles epidemic is affecting adult medicine doctors every day. All right, so let's go ahead. I'm going to start with a case. This is a patient that I took care of in early February, who was a 53-year-old woman, otherwise very healthy except for some mild hypertension. She presented to an emergency department with a 4-day respiratory illness that began while she was out of town for a family event. The timeline was on a Thursday. She developed fevers, fatigue, cough, and a sore throat. On Friday, while out of town, she visited an urgent care, was tested for respiratory viruses. COVID-19 testing was negative, but her flu A was reported positive, and the prescriber gave her oseltamivir. However, since she was returning home on the following day, she elected to wait to fill the prescription. On Sunday, she was continuing to feel poorly, now with a productive cough and shortness of breath, which was new. And so that was what led her to the emergency department. On arrival in the emergency department, she was febrile. She had hypotension. She was tachypnic and tachycardic. Her white count was not particularly elevated, but her lactate was, and she had some new acute kidney injury. She had a multilobar pneumonia, representative imaging on the slide. And she was admitted to our medical ICU for fluid resuscitation and care for septic shock. About 18 hours into her stay, she developed an acute change in mental status, had a CT scan which showed diffuse leptomeningeal enhancement. She underwent a lumbar puncture that was grossly positive and consistent with bacterial meningitis, and her gram stain was positive for gram-positive diplococci. Ultimately, about 9 days into this illness, the patient continued to clinically worsen, developed worsening neurologic disease, despite maximal treatment in an ICU setting, ultimately went into status and eventually lost reflexes and died 9 days into the illness. This was a healthy person prior to all of this. She was unvaccinated for influenza. She was also, according to family, unaware of pneumococcal vaccine recommendations for people aged 50 and older. And so this is a case of one of many that we saw in a very severe flu season this year of a patient who developed bacterial pneumonia as a secondary complication of influenza. In this particular patient's case, she developed pneumococcal bacteremia, ultimately pneumococcal meningitis, and expired as a result of these two vaccine-preventable diseases. During this same week, we saw multiple other people with secondary bacterial pneumonias, either caused by Staph aureus or pneumococcus, patients who required ECMO. And we even, during this peak week in February, identified several patients who had nosocomial influenza from being in the hospital and acquiring it either from visitors or others in the hospital. And so this was a peak point in flu, and we'll go to the next slide. And this just sort of highlights during that week how severe influenza was across the United States. And almost all of the states are in red, which is high, and many of the states are even beyond high or very high with that dark purple or blue coloring. So flu season, if you go to the next slide, was ultimately classified as high severity for all age groups by the Centers for Disease Control. During this particular flu season, which we are still in the tail end of, there were estimated since October between 46 and 81 million cases of influenza. About 21 to 36 million of those cases ended up with some sort of a medical visit. Between 600,000 and 1.3 million required hospitalization, similar to the case that I just discussed. And 26 to 130,000 deaths have been estimated, including deaths in children. So this was one of our most severe flu seasons. And in fact, if you look back through our archived data that CDC keeps very nicely or has kept very nicely, this was the most severe influenza season since the 2017-2018 season. That was the last time that we had a high severity flu season. Next slide. So you may be wondering, was it a poor match? Was the vaccine not particularly effective this year? And the answer is no, the vaccine was effective. The strain choices seemed to reflect what was circulating, although we have less than complete data about some of the circulating strains this year because of the changeover in the administration. But what we know is that for adults, the vaccine effectiveness was somewhere between 36 to 54% in ambulatory settings, and was protective around between 41 and 55% to preventing hospitalization for adults who had been infected after having a flu vaccine. Among children and adolescents, this year's flu vaccine was estimated to be anywhere between 32 to 60% effective in outpatient settings and between 63 and 78% effective in preventing influenza-associated hospitalizations for children and adolescents. And so the vaccine this year was a good match, but it was ultimately not used as effectively or as broadly. And so we really didn't put a dent in many of the hospitalizations that ended up happening this year. Why was that? Next slide. So these are two maps. Left-hand side just really shows this year's uptake of vaccination across the United States. And while the map is in different shades of blue, what I will tell you is that all but the darkest shades represent under 50% vaccination uptake rates in these states. And so when you don't get a high degree of vaccine uptake in your state or community, your entire community is then more at risk for transmission of flu and the severe outcomes, including hospitalization, ICU care, and in some cases, death. And so we are really, as a nation, not vaccinating half of the population, and in some cases, far lower than that. And that is going to probably continue to get worse as time goes on, especially with the lack of public health infrastructure and messaging and communication. And you can see that compared to the prior year, most states were about the same. So basically, we were no better this year than last year, and basically overall, less than half of our population is taking a flu vaccine. Next slide. This is from CDC data, and what this really tells us is that in each successive season over the last 4 seasons, starting with the 21-22 flu season, we are seeing less vaccine usage across the United States year over year. So this is a problem that is getting slowly worse over time, and I would actually, in some ways, suggest that some of the increased vaccine hesitancy and blowback against vaccines is in part, unfortunately, due to misinformation and disinformation about the COVID vaccine and some of the distrust that was sowed around public health in the COVID-19 pandemic, now resulting in less and less people being interested or believing in the benefits of vaccination. Next slide. So vaccine hesitancy in adults is rising here in the United States. This is just one particular article that I'll reference. In this particular article, looking at both COVID-19 and flu vaccine hesitancy among adults who've been hospitalized. The top 4 reasons for no flu vaccine: never got around to it, don't believe it is important to my health, believe it is dangerous to my health, or I've had flu in the past, I've had the vaccine in the past and still got the flu, so I don't need the vaccine. It doesn't really work. It's not of benefit. I don't need to prioritize getting it. I think it's important to understand these reasons because as healthcare providers, that is key to us being able to effectively educate, communicate, and influence our patients at the bedside or in the office to accept vaccines and to try to sort of beat back a lot of this disinformation or malaise that set in around vaccination. Next slide. So I just want to call out for everyone, just so not everybody may know this. What's the usual process for annual flu vaccine updates and strain determination? Dr. Offit knows this very well. He is involved, as Lynn mentioned earlier, in the Vaccine Advisory Committee. But it usually goes something like this. Over the course of the year, at the beginning of a calendar year, the global surveillance on the viral strains is being tracked by the World Health Organization, who convenes meetings twice yearly to determine which strains are circulating in the northern and the southern hemispheres. And they use that data to then share that with the FDA and other bodies across the globe to help them make decisions about which strains are then going to be put into the manufacturing of the next season's flu vaccines. And that usually sometime in March, the FDA convenes their outside panel of vaccine experts and together with the Vaccine Advisory Committee, they choose those strains, give that information to the manufacturers. They then begin production. Eventually, at the end of the summer or in July, they will the companies will submit to the FDA for approval of the new vaccines. And then the CDC and the ACIP put forth their recommendations for vaccination for the upcoming respiratory virus and flu season. And that's how it's always worked. And I just boxed out this one area because if you go to the next slide, we had a change in this usual process this year. The FDA canceled the meeting of the independent advisors and ended up deciding on strains without the benefit of that group really providing some discussion and input. Now, I mention this because they did ultimately make a choice. They did share that information. The vaccines are in production. But I don't know how the rest of the year is going to play out. Um, I don't know whether or not the vaccine will be robustly recommended by the CDC or ACIP. I have no idea what messaging will come out at the end of the summer about flu vaccine, and I worry about that because even assuming that the process does play out, how strong will the recommendations be for influenza vaccine going into next respiratory virus season? What kind of public service messaging and other types of things will public health do, which they traditionally have always done every year? Will our public, our population, be less inclined next year again, as they have been in the last 4 prior years, to getting flu shots? If we know that there's a lot of unpredictability with the respiratory virus season, including the timing of onset, whether or not it coincides with other circulating viruses like RSV or COVID-19. And we also will not know until well into the season whether or not the strains that were chosen to be placed into the vaccine for the next year are a match to the circulating strains. And ultimately, all of this unpredictability, and if there isn't a good, robust messaging component and influence campaign around the importance of flu vaccine, I suspect we will see less vaccine uptake. And if we have a high severity flu season like we did this year, that is going to have a ripple effect not only on patients and their health, but it also has large ripple effects on our hospital systems. It strains our emergency departments. It strains our offices. It leads to boarding in emergency departments, increased length of stay, inability to get people into beds who have other illnesses. So all of those things can really make all of us less safe. And so it just is another way to think about how important flu vaccine truly is to and the compact that we have among communities to getting people vaccinated to keep everybody's health better than it could otherwise be. Next slide. So a couple of things. The patient that I talked about at the beginning of my remarks also was not vaccinated for pneumococcal vaccine, and she was 53 years old. So recently, before the current administration, the CDC and ACIP did change the age, lowering the age for recommendation for pneumococcal vaccine from 64 to 50. But a lot of people don't actually know this. So and there has been and I've heard it in my car driving to work, public service announcements encouraging people 50 and older to get vaccinated for pneumococcal vaccine, for pneumococcal disease. Next slide. What is the current population's vaccination rates? So we don't have super current data. The last year for which data is reported by CDC is 2022. And at that point, individuals between the ages of 19 and 64 at increased risk for invasive pneumococcal disease had a vaccination rate of 23% in 2022. We were doing better in patients 65 or older, in which in 2022, 64% of people had received at least one dose of any type of pneumococcal vaccine. So better in the patient population of 65 and older, but pretty abysmal in 19 to 64. And as I learned many, many years ago, we all have to have a very healthy respect for the pneumococcus. And I outlined that in the case that I presented earlier, because it will take down very healthy people, and it is one of the most common secondary bacterial pneumonia causes in people who develop influenza. Next slide. There is pneumococcal vaccine hesitancy among adults. There's one article that I've referenced here, and there are many others. The bottom line is that there are two sorts of barriers here. One set of barriers is with the patient, but the other is with the providers. Patients have a general lack of awareness of the disease and its risk among patients and themselves and others. There's obviously always a fear of side effects. There's an assessment of risk versus benefit, not really understanding the disease. They think the benefit to something like this is modest to them, and so they don't feel particularly inclined to the vaccine. Obviously, as we've been talking to about and alluding, distrust and misinformation continue to abound about the importance and efficacy of these vaccines. And depending upon the community in which individuals live, they are going to be more or less inclined to vaccine or more or less inclined to skepticism and hesitancy. In terms of the healthcare providers, one of the barriers is just not really having knowledge of the newer guidance. People are still thinking that it's 65 and older. Many times providers don't have time for the education and the conversation that they need to have to make sure that their patient understands the importance of the vaccination. And one of the other provider barriers is really simply just a reminder to talk to the patient about it. Electronic medical records can provide that reminder and can actually be the place that fosters the conversation up front. I will say that in several articles and publications, one of the best ways that and most effective ways that we can battle vaccine hesitancy among patients is having a trusted relationship with a healthcare provider, someone that they trust, that they have an established relationship with. And patients will say in study after study that when their doctor tells them they think that this is of benefit and important to their health, they are more inclined to accept that vaccine. Next slide. And so, as I mentioned, I'm just going to touch on measles very briefly. As adult doctors, this has now spilled into adult medicine and adult clinics, and everybody is asking lots and lots of questions about measles among adult doctors. On the patient side, patients are asking their healthcare providers, do I need to get another measles booster? Sorry, Paul, I just used that term because that's what the patients say. They ask, I don't know if I was ever vaccinated for measles. What should I do? Another patient may ask, I have a rash. I'm concerned it could be measles. There have been a lot of those messages that healthcare providers have gotten. And on the healthcare provider side, healthcare providers are asking each other and ID doctors, what's the incubation period for measles? I have a patient who was born in 1964. Do they need 1 or 2 shots? When should I order measles antibody titers on my patients? And these are just some of the questions that we have been deluged with over the last 3 months as the measles outbreak has just, been a wildfire across the United States. Next slide. I'll just share, we've put out successive information in the last 3 months. First, we started with just an FAQ to give people sort of the general gist of what you need to know about measles. Then we had to do a separate FAQ on measles vaccination and immunity. It was a 2-page document really to help frontline providers to navigate all the questions that they were getting from patients and the questions they were asking each other. And then we more recently put out a measles explainer video because, again, we are still getting questions from many areas about, what is this disease? What do we need to know? And as Paul mentioned at the top, there are very few physicians rounding in hospitals or providers who have ever seen a case. So there's a lot of questioning about it. Next slide. This is my final slide. I just wanted to sort of wrap it all up by saying that depending on our public health partners right now to do the traditional work of vaccine messaging, education, influence, tracking of diseases, as we move into the next respiratory virus season and beyond is really in question. I think societies are going to have to step up. Other groups are going to professional groups are going to have to step up to try to help with this because I don't think we can depend on the public health partnership that we've had for decades as the administration has really decimated CDC and public health. Individual healthcare providers are going to really be on the forefront of this. We are going to have to do this one patient at a time, establishing a trustworthy relationship, being able to educate and influence our patients to accept vaccination and understanding that it is in their best health interest to do so. And we have to do that through building trust. And I'll stop there. Thank you.
Thank you. That was great. My first question, and it's an easy one, is, can we get access to those FAQs in the video?
I can definitely give you access to the FAQs. I don't know that I can share the video, but sure, I can give you that.
And it would be good for us to see it, but we could also put it out on things like Facebook and Instagram. Would that be something, or are they, kind of property of the university and you?
I can de-identify them, de-logo them, debrand them, and yeah, there's just general information. They're not, there's nothing, proprietary about the information. It's just putting it all in one place.
Yeah, and just getting it to one place where you don't have to go looking on the web and,
Right.
would just be great. Um, so, our flu numbers, how do they compare with other countries? Not Albania possibly, but France and Germany. And are they doing a much better job of getting vaccines, or is this kind of getting to be a worldwide problem?
So it was a pretty significant flu season throughout the Northern Hemisphere. Obviously the Southern Hemisphere before us, so last summer when it was their winter, they had a fairly robust season as well. Um, but I don't think it was quite as severe as it was in the Northern Hemisphere this past winter. So in terms of though, answering the question about other countries' vaccination rates, ours are not as good as some of, like, for our example, our northern neighbors. I don't know that I know vaccine compliance data in other countries in Europe, but um, if markers of other vaccines, like uptake of COVID-19 vaccines, for example, is any sort of suggestion of what it would be like, we know that uptake has been better there in Europe than it has been here in more recent years.
Okay. Um, the pandemic, for many reasons, and a lot of the questions in the chat are kind of looking like this too, have led to a loss of faith in medical institutions. Do you have ideas about how we can regain that trust, except for just having individual providers make relationships with patients, and in the face of the current HHS?
Paul, do you want to take that one?
Yes, I can start off. Well, I think it's true. I mean, as Dr. O'Donnell said earlier, I think the COVID pandemic definitely alienated a decent percentage of this population in terms of how they viewed the public healthcare system and scientists and doctors. And I think there were two things that happened. I think in 2020, we didn't have anything. Virus came in, started killing people by February of 2020. We didn't have antivirals till October. We didn't have monoclonals till November. We didn't have vaccines till December of 2020 to try and prevent a disease that was spread asymptomatically. And so anybody you came in contact with could essentially transmit a virus that could kill you. So what did we do? We shuttered schools, we closed businesses, we restricted travel, we isolated, quarantined, masked, distanced, and that was by a significant percentage of this population seen as massive government overreach. Then when we had a vaccine the following year, 2021, we mandated it. And so you couldn't go to your favorite bar or restaurant or sporting event or work, or you may be fired from work. And that too was seen as massive government overreach. And we didn't always get it right. I mean, there were things that we said that weren't exactly right because you learn as you go. This is the nature of science. You learn as you go. You have to be open-minded to that. And I think we probably could have done a better job of making it clear that we were making decisions with the best available information. I mean, I'm on the FDA Vaccine Advisory Committee. In December of 2020, when we looked at Pfizer and Moderna's data, you're looking at data on, in the case of Pfizer's vaccine, 20,000 people got the vaccine. Moderna, 15,000 people got the vaccine. You were about to make a recommendation for hundreds of millions of people. You know the other shoe was going to drop because there's always a human price to pay for knowledge. That's always true for any medical innovation. And this was a novel virus that was being met with a novel technology. So I think that's all true. So the question was how to get it back. I think we have to. I wish I knew the answer to that question. I look at people like Ayla Stanford in Philadelphia, who was an African American surgeon at Temple who formed something called the Black Doctors COVID Consortium. And what she did was she went into North Philadelphia with a predominantly Black and brown community that was highly under vaccinated. And she just sat in their living rooms And here's somebody they trust, and somebody who would look like them, who then she just went back again and again and again and immunized 50,000 people in that region. So I think it's a matter of finding who people are trusting, and then try and influence those who are trusting them. And I think that's probably our best bet. I mean, the more grim answer is, more people are infected and arguably die from measles, and now pertussis is another disease that we had last year, 2024, we had 6 times more cases of pertussis than the previous year. This year, we have 4 times more cases than last year. And you're seeing a number of states that are seeing pertussis deaths that hadn't seen pertussis deaths in a while. So, I mean, the viruses and bacteria are coming to get us, and hopefully that's not how we educate ourselves, because that's a grim way to educate ourselves.
Thank you. There are also several questions about whether the administration is going to cut down money for pediatric vaccines and to slow the development of new vaccines, particularly the mRNA-based ones. Um, Either of you thoughts about that?
I can start off because this is
Please.
the thing for me. I mean, as a pediatrician, I think that the goal of the current Secretary of Health and Human Services is to make vaccines less available, less affordable, and more feared. Has for 20 years been a virulent anti-vaccine activist, science denialist, and conspiracy theorist. Why anybody thought he would be a different person when he was no longer paid by the anti-vaccine organization Children's Health Defense and was now paid by you and me as a federal government, that he would now represent the public's health. I'm not sure why anybody thought that. But so look at what he's doing. Just in the last couple of days, he said he is considering removing COVID vaccine from the childhood immunization schedule. I have had a number of people tell me that he is now trying to work around the vaccine injury compensation program. If that's true, if he does that, because remember he said he's going to now do a study about the causes of autism. And he said exposures that lead to, and he said autism is preventable. But it already tells you where he's coming from. He's not going to go at the genetics of autism. He's not going to go at like maternal health issues. He's going at vaccines. That's what he's doing. And I think what's going to happen is in the next few months or so, he's going to say, I've looked behind the curtain of the FDA. I've looked behind the curtain of the CDC, and I'm appalled by what I've found. In fact, vaccines do cause autism, and they've been hiding this all along. And then he could change the injury compensation program. He could pull vaccines out of the vaccine injury compensation program. Do that, and we'll be right back to where we were in the early 1980s, when we had 18 companies that made vaccines, but due to a flood of civil litigation, by the end of the decade, we had 4. And this is a fragile market. Although obviously we all look at the COVID vaccines as a windfall for Pfizer and Moderna, and it was, but vaccines are something you give once or a few times in your lifetime. They are never going to compete with these drugs that are given every day. They're less than 10% of what these companies do. They could drop it in a second. Make it expensive enough for them to do this by putting them in the slings and arrows of civil litigation, and they'll leave it. So I am really worried about what's about to happen with pediatric vaccines. I already know that, J&J, for example, is now out of the vaccine business. They're not going to make another vaccine again. And I do worry about this, but I'm curious to hear Dr. O'Donnell's comments.
No, I don't have anything much to add to that. I think that Paul said it absolutely perfectly. Yeah, I'll just leave it at that. I completely agree.
You are both making our first question asker very happy because they do not like how we keep on using terms like misinformation. They'd rather that we just come out and say things like lies and falsehood. So I think that will help a lot. There is a question about whether we should try to get ahead of the information by pre-bunking information coming out from HHS. You might recognize where that's coming from, anticipating the results of the autism study. Do you guys have any ideas for that? How we could kind of prepare for this to happen to maybe lower the impact when it happens?
You want to start it off, Judy?
Yeah, I mean, I think, again, we're not going to be able to count on public health to be the main place from which science-based messages and communications that are targeted towards different communities will be, pushed out. I think that this information, I think that societies, professional societies, the ID Society, the American Academy of Pediatrics, the American, the Department, the medicine, internal medicine, et cetera. I think these different societies are really going to have to step up to try to do some coordinated communication. I'm hopeful that that is what will happen. I have heard from people that are in leadership positions in societies that they would like to do that. I Because again, it will not be effective to try to do this like in a hand-to-hand combat sort of way. Like you can't change enough minds in an office. You really have to have a platform that is trusted and that you can sort of get that message out. And I think that I like the term pre-bunking. I do think that there's going to have to be messaging that comes out along the way ahead of any of these studies to keep reminding the public of what the facts truly are, and that I think the other thing that we have to call out is people can twist data in ways that can be very misleading. And that can be one of our that leads to distrust in science, because if a top line message is not particularly all the story, but grabs a headline, but then when you really go into the data, that's really not the conclusion. We look bad as scientists because it seems like, do you really trust the data if somebody's looking at it one way and somebody's looking at another? So I do think it's important to recognize what science can and cannot do, to recognize the limitations of science, but to try to get some improvement in science and health literacy among our population so that they can better understand this information. In some ways, I do feel very skeptical about this because the wave of information that people get every day from unreliable sources like social media platforms is almost it's a tsunami, and I don't know that we can truly prevent it, but I think we have to at least try.
That's perfect. The only thing on that is I think we had sort of a hint of this during RFK Jr.'s second confirmation hearing, when both Senator Sanders and Senator Cassidy tried to get him to say, "You do agree that vaccines don't cause autism." He would never say that. Just wouldn't say it. Show me a paper. Show me a gold standard paper, and I'll say that. And so, but at the end of the second hearing, he holds up a paper by Mawson and colleagues, which was not published in a scientific journal, not published in a medical journal. It was not peer reviewed. It was funded by anti-vaccine groups. It was horribly flawed. I mean, so methodologically flawed that its results were absolutely uninterpretable. Okay, but when he holds that up, I think what we have to do immediately is get into people's hands the why it was so flawed very quickly. And I think there are a lot of social media sites that do that, like Unbiased Science and Science-Based Medicine, really put into the hands of clinicians who are maybe asked this question. Here's how you refute this. And I think that's our best bet, because you don't know exactly what he's going to say, RFK Jr., other than he's going to find some way to shoehorn data into his fixed, immutable, science-resistant hypothesis that vaccines cause autism. And I just think we're in for a bigger fight. He's been doing this for 20 years. The difference now is he's in a policy-making position.
Yeah.
That's the difference.
Do you think that groups like DFA and possibly PNHP would be helpful in trying to get this information around, or whether it's better to stick with the medical societies?
Everybody. There's
Everybody.
Sarah McBride, who's a Democratic senator from Delaware, said it best. She says, as long as if everybody's a little courageous, then no one has to be a hero. So I think the more people that stand up here, the better.
We tend to listen to our news. We get the news that we want, and so it's very difficult. We have another question about, are we as physicians not doing our jobs and getting our patients to get appropriate vaccines? I know that you both touched on this a little bit. Is there anything else that you'd want to tell us that we could do?
Well, I mean, the one thing I will say is something that I had in my slides, which is that we do have to give ourselves a little bit of of grace around this, because in the middle of a very busy visit in which you're often only allotted a 15 or 20-minute time period to see a patient and manage multiple diseases, especially for adult doctors, where patients have lots of things to come in with. They have their complaint. Then you want to look at other options other things when they're in the office. It can be difficult to do everything that you need to do to get the patient to a point where they're going to accept the vaccine. So I think that, yes, we could be doing better. I do think that things like electronic medical records that really have a reminder that pings, is truly a helpful thing, and it's been shown to be effective because it reminds the provider in the moment, "Oh, this is somebody who needs their flu vaccine right now. I can make a difference." And obviously having opportunities for vaccination in, I think, many of our commercial pharmacies is wonderful. It's really given more people a more convenient opportunity to become get vaccinated against these diseases. And so I think, oftentimes we'll even encourage patients, if you don't want to get it now, go to your local pharmacy in a week or 2 weeks and get it there, and just let us know that you got it. So I do think that, we could always do a better job. We need to keep messaging more now than ever to our patients, and hopefully persuading them.
Yeah, I would just from the pediatric perspective, I would offer this. I think we ask a lot of parents in this country. We do. We ask them in the first few years of life to inoculate their children with vaccines to prevent 14 different diseases, which can mean as many as 25 shots during that period of time. It can mean as many as 5 shots at one time to prevent diseases most people don't see, using biological fluids most people don't understand. I think it is understandable that there's pushback. I think it's amazing that some people don't push back. I mean, you should be skeptical. You should be skeptical of anything that you put into your body, your child's body. Where are the data? Fair enough. But I think I've watched my wife go through this. I mean, I'm not in private practice pediatrics, but my wife is. So I'm watching her go through this. And what she does is she just did the best she could initially, trying to explain people about the importance of disease. And then ultimately she had it. And she did something that made her much more successful, was she basically laid it on the line. She said, let me love your child. Don't put me in a position where you're asking me to send this child out of this office without these vaccines, knowing that there's measles out there, knowing that there's whooping cough out there, knowing that there's pneumococcus out there, knowing that there's chickenpox out there. Please don't do that to me. I can't do it. And with that, she became far more convincing. But I think it's very hard for us to do that as physicians because we don't like any sort of confrontation. But you're the patient's advocate.
I was astounded to find out that I had a couple of anti-vaxxers in my family. As a pediatrician, I've been telling my kids since they were little about the complicated cases I saw that would have been avoided if they had just gotten their vaccines, but it still happened. Um, we have another question about the array of mRNA vaccines in development is impressive, and some are far along. Will the NIH cuts doom them for the near future?
Well, I just saw Dave Bhattacharya's tweet yesterday or the day before, where he said, there's too much we don't know about mRNA vaccines. We don't know the dose because, obviously we're an outbred population and the degree to which that mRNA is translated may be different among different people. It's not like giving 50 micrograms of an antigen. We don't know where these proteins are going, which is absolutely not true. So he said he is considering suspending funding for the mRNA platform. I mean, I can only hope he was kidding because this is all very frightening. We are in a tough time, but this will not last. This is not going to last. It can't. It's built on sand. It has to collapse on itself.
Hopefully without too many deaths when it collapses. We have another specific question. Can vaccinated individuals be carriers of the measles virus, like vaccinated COVID carriers?
I think the measles, remember, this is a long incubation period disease. So, 7 days, 10 days, sometimes as long as 21 days. So all you need is immunological memory. I mean, the reason you can eliminate a virus like measles or polio or rubella or smallpox, which are all long incubation period diseases, is that all you need is memory. So that's why you can have lifelong protection. And because memory cells can be activated and differentiate to become, antibody secreting B cells, that can even prevent mild infection. So no, I don't think you're a measles carrier. I think when you can eliminate a disease entirely, it's because it's a long incubation period that only requires memory. Because remember, it takes a while to get sick. So that's plenty of time for activation and differentiation of those memory cells. So I think no.
Dr. O'Donnell, you mentioned that childhood vaccines are important for adults too. It's a great point of I knew it intellectually, but it kind of wasn't in my mind all the time. I wonder if putting that message out would be helpful to people. We don't think
I
about
think yeah, adults reap the benefits of a well-vaccinated group of children and adolescents, and when you think about, the distribution of the population, there's far more of us than there are of them, and so vaccinating them really helps the wider community around them, and the adults that are around them, and, we have seen that in action with the measles outbreaks. As vaccination rates have fallen for measles, we're seeing outbreaks in children, but we're also seeing adults being involved now. And, the consequences can be just as bad for adults, if not worse, depending upon the individual adult's, health comorbidities. And so, yes, I mean, it's one of those sort of community health, public health compacts that, as a community, we are going to commit to vaccinating our children to keep all of us healthier. And adults are going to get vaccinated to prevent diseases back to children before they can get immunized, right? I mean, adults could pass on measles to a 6-month-old and probably have. Adults can pass on pertussis. And so there is truly a compact both ways. But we get a lot of benefits from childhood vaccination among the adult population, and when you see that decrease, this is what we're left with.
Yeah, I would love to see more of that out there. We have another question saying most people aren't that savvy about science data. We need somebody who can speak a story that will resonate like Taylor Swift. That would be just a great idea if we could get somebody like that. And also, talking about the doctors in Philadelphia that went out to the Black and brown communities, getting people from those communities also out there. I think would be really fun. And this person really wants all the medical societies to come together. I think that is about it. Oh, somebody just wants a reminder about the incubation periods for rubella, pertussis, and mumps, which you guys would be good at. Probably, Dr. Offit, you more likely.
Well, rubella and mumps have relatively longer incubation periods. Pertussis, no. Pertussis is a short incubation period mucosal infection, which is why if the entire world were vaccinated against pertussis, that bacteria would still circulate. I mean, the one mistake I think we made with COVID vaccine very early, talking December 2020, we should have made it very clear this is a vaccine to keep you out of the hospital, keep you out of the ICU, keep you out of the morgue. 6 months, or so after you've gotten the vaccine, and as antibodies in the circulation start to come down, you may well get a mild or moderate infection, but that's not the goal. Okay. So as long as you're out of the hospital, you won. And I think we didn't explain that because we mandated vaccines in 2021 and people would still get, say, a mild infection. They're home for a couple of days, they're coughing, they have high fever, and they say, they told me this vaccine was going to work. They lied to me. I think we should have made that clear.
Yeah, and indeed, that was one of the 4 points that Dr. O'Donnell gave about why people said they didn't get vaccinated, was
For
that they
flu, yeah. And I mean, I find that sometimes even people that have high health literacy don't get the nuance there. That and somebody did put a question in the chat saying, is it disingenuous to call influenza a vaccine preventable disease? And I get what they're going after there because it doesn't always prevent flu. It does in some people, but what it does truly prevent, and we've got decades of data to support this, is that it prevents you from getting truly sick, ending up in the hospital or in an ICU or on ECMO or dead. So that's what it does. And as Paul said, if it does that, you've won. We've all won.
And you see they had a really good campaign. It was now they've had to take it down, and they're trying to bring wild to mild. It's exactly.
Yes. Yes, that was great. Yes, I loved that. Yeah.
So there are a couple of questions about immunocompromised people, which are now, I guess, about 6% of the population, according to this question. And then a question about from the CDC warning people with family members, kind of unclear a little bit about exactly what they say and how those immunocompromised people will affect future epidemics.
What was the specific overall? I'm looking, how will that affect?
So the one,
Okay, got it. So yeah, as we have a population of adults who are more immunocompromised for a variety of reasons, either because of innate disease or because of biologic medications that we are giving them to prevent diseases from recurring or cancer, et cetera. Yes, we have a growing number of people among us who are considered moderately to severely immunocompromised, and similar to, what we saw in the first wave of SARS-CoV-2 infections in 2020, we saw that, a lot of the most vulnerable people were the ones who landed very quickly in the hospital and had significant disease. And so, I would say that the more immunocompromised people that we have, the more likely it is that those individuals are at greater risk. I don't think that they're at an increased risk of transmitting disease in any way, although we do have a lot of data that tells us that in immunocompromised individuals, SARS-CoV-2 can continue to replicate at low levels and can evolve over time into different different variants. So that happens with that particular disease. I don't know that it would happen with the next pandemic or a flu pandemic. Who's to say? But I do, yes, immunocompromised people are going to continue to, unfortunately, have the greatest risk among the whole population with pandemics or other severe diseases.
okay, one last question before we close. This questioner had to get her titers checked or his titers checked before starting medical school, and rubella and measles immunity was gone. Should we start thinking about checking people's titers, or at least for people in hospitals that are working in hospitals that are around infected people more?
You're right. I'm gonna probably have a contrary point of view here, but these are long incubation period diseases, measles and rubella. That's why we eliminated rubella by 2005 and measles by 2000. So it's really memory that you care about. I mean, years after a vaccination, as antibodies may start to fade, but that doesn't mean that you don't have memory, because historically, the way this plays out epidemiologically is that if you were naturally infected or you've gotten even one dose of vaccine, you for the most part are protected for the rest of your life. And it's not because you have circulating antibodies for 40 years. So I'm not a big fan of that. My feeling is if you've been vaccinated, I think it's reasonable to consider yourself protected, but that is a minority view because everybody's getting tired. A lot of people are getting titers these days.
It might be hard to try to get people to do yet another thing, so
Yeah, and I actually agree. I think there's a very small proportion of people for whom titers are probably a reasonable thing to check. But I certainly and we're not recommending, broad checking of titers. Obviously, it depends on where a healthcare provider works, but most hospitals and systems do have requirements around, measles immunity, rubella immunity in order to be able to work there, and some occupational health services will do titer checks prior to full employment. And so, in that scenario, as the questioner asked, I guess, that then calls into question, do they need another dose? And to Paul's point, probably not, but that doesn't mean that they don't get it.
yeah, and that kind of thing, though, is something that people get upset about, if they're made to get a vaccine that they don't necessarily need for the rules.
Yeah.
I think that's kind of one of the reasons that we've lost trust, or an example of that.
Yeah.
Okay, thank you guys so much. That was wonderful, very thought-provoking. I learned a lot. We are grateful that you could join us. But before everyone else leaves, I'd like to give a couple of reminders. Education's important, and so is action. So please either submit a video to the DFA Vaccine Preventable Illness Story portal. The stories are wonderful and are often really helpful for politicians and other people to really get an idea of what patients are going through. Another idea is to write an op-ed or a letter to the editor, to your local paper. Share what you've learned with your friends and colleagues at lunch or breakfast or whenever, and invite others to join DFA's work. And then remember that tomorrow night we have our Code Blue advocacy meeting with the link is in the chat. And then finally, thank you all for being here. We hope you'll become an official DFA member today. Um, and one of the main reasons people join DFA is to be with like-minded people. And certainly from the questions and people's interest, it felt wonderful to have people here that I felt really comfortable with, that we were kind of on the same page for all this stuff. So thank you and good night.